Welcome to the first SAPNA Annual Educational Conference Series.
Welcome to the Medical Patient and Psychiatric Symptoms and Illness for the Acute Care Nurse. This is a 4-part series workshop conducted by me, Leticia Flores Canchola, and I am a student for North Central University conducting a research for my PhD dissertation. Disclosure to participants. University Health is an approved provider for continuing nursing education. To receive contact hours for this continuing education activity, the participant must attend the entire program, complete the pre- and post questionnaire, and complete the evaluation tool. Once successful completion has been verified, a certificate of success completion will be awarded for a 4.0 contact hours. The planning committee members and the presenters, authors, content reviewers of this CNE activity have disclosed no relevant financial relationships related to the planning or implementation of this CNE activity. Here are the objectives. There are 8 objectives that will be met by the end of the presentation. As human beings, we exist in a society composed of many different types of people. Although genetics provides a blueprint for our physical body, the human mind is unique in that it contains a combination of our thoughts, perception, memories, emotions, will, and reasoning. Each of these is developed as we think, feel, and react to the world around us. We interact with our own thoughts in a private way with the ability to communicate them to others as we choose. The well-being of this aspect of our body may be referred to as a state of health of the mind. Mental health. According to the World Health Organization, mental health can be viewed as a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make contribution to his or her community. Resiliency. Resiliency is closely associated with the process of adapting and helps people facing tragedies, loss, trauma, and severe stress. Disasters such as the attack of the World Trade Center in 2001 and the devastation of Hurricane Katrina in 2005, in which people pulled together to help one another and carried in despite horrendous loss, illustrates resiliency. Being resilient does not mean being unaffected by stressors. It means that rather than being the victim to negative emotions, resilient people recognize the feelings, readily deal with them, and learn from their experience. As nurses, we also need to know the differences between mental disturbances and mental illness and disorders. Mental disturbance is the behavioral or psychological changes occurring to an individual associated with distress, such as pain, impairment, and functioning. Mental illness disorder is significant changes in behavioral and psychological changes interfering with the individual's 5 major pathways. The pathways include executive functioning skill, language skills, emotional regulation skills, social skills, and cognitive flexibility skills. What are some of the medical conditions that may be associated with signs and symptoms of mental illness? Remember, the mind and body are related to one another. We are more than our parts. As nurses, we need to provide treatment to the person as a whole. Some of those common medical conditions associated with psychiatric symptoms and/or with illness can be cancer, diabetes, chronic pain, dementia, delirium, gastrointestinal, and pancreatitis. Each one of these medical conditions can also illustrate or demonstrate anxiety, depression, alcohol withdrawal, personality changes, fatigue, headaches, and confusion. Here are some more common medical conditions associated with psychiatric symptoms and/or illness: liver disease, multiple sclerosis, intellectual disability, traumatic injuries, infectious disease, respiratory infections, skin infections. And with any medical diagnosis, a patient may have signs and symptoms of depression, anxiety, sleep disruptions, memory lapses, personality changes, lack of motivation, concentration problems. They may become suicidal. They may have signs and symptoms of PTSD, confusion, hallucinations, and aggression, plus some more. As with liver disease, can mimic a mental illness due to high levels of ammonia, the way a person who is newly diagnosed with a medical problem may respond to the increase of stress and anxiety. Stress and anxiety can arise from any thought or issue that creates frustration or feeling of uneasiness. Situations are differently viewed by everyone, with some things being stressful to one and not to others. When we're dealing with a crisis situation, especially with the crisis of newly diagnosis, we need to have crisis intervention, which deals with the present situation and resolution of the immediate issue. Early intervention is assisting the individual to manage the current situation, promote the best chance for a positive outcome. Now, the 4 most common personality disorders: antisocial, narcissistic, borderline, histrionic. As a cluster, their behaviors are described as dramatic, emotional, and/or erratic. Antisocial signs and symptoms: lack of empathy, antagonistic, impulsive, deceitful, manipulative, hostile, explosive, lack of remorse, suspicious of others. Narcissistic signs and symptoms are entitlement, exaggerated beliefs in one's own importance, lack empathy, they're arrogant, grandiose in sense of self-importance, they love admiration and approval from others. They also have poor insight into their behaviors. Borderlines, they're unstable relationships, they're insecure and have poor self-image, mood swings, impulse outbursts of anger, chronic sense of abandonment, they're clingy and dependent, they manipulative behaviors. They also have suicidal thoughts, and they love splitting among nurses and techs. Your histrionic, signs and symptoms are attention-seeking, provocative sexual behaviors, overly dramatic, exaggerated behaviors. They're shallow, they're superficial in relationships, they're melodramatic and vague, manipulative, and they have unmet dependency needs. Their interventions is provide a safe environment, set and maintain limits with consequence, require the patient to take responsibility of his own behavior, do not make exceptions and show favoritism, encourage the patient to openly express feelings and thoughts, communicate problems with manipulative clients or patients, approach patients from the front and speak clearly. As nurses, we have our goals and we also have our outcomes. Our goal as nurses is to manage signs and symptoms, manage behaviors, have safe environment, be effective and efficient with your work and the treatment you're providing to your patients, provide the best care, reduce risk and complications of the patient. Our ultimate goal is to prevent, minimize, stabilize, have less problems, and a smoother shift. Many hospitalized patients are in crisis. They may be experiencing anxiety, unusual behaviors, or symptoms that can go beyond a person's typical coping. They may be acting out, regress to earlier stages of development, express atypical, odd, or difficult behaviors, and/or just behave differently than their usual selves. In general, medical surgical patients are sicker, increasingly more complex, and have more comorbidities. Any hospitalized patient, regardless of diagnosis, can have behavioral symptoms and/or be in a crisis situation. They can also have a barrier to quality care and make nursing's jobs a lot harder. Understanding their behaviors is, in general, medical patients are sicker and are more complex and have more comorbidities. Any hospitalized patient can be in a crisis and/or have psychological symptoms, thus creating barriers to quality of care due to nursing stigma. Recognizing signs and symptoms of behavior is very important. When a patient starts feeling anxious, stressed, feels out of control, maybe having severe anxious that will lead to panic attacks, they can become angry, start acting out, they become aggressive, agitated, which may lead to violence. They may be bored, overwhelmed due to under or overstimulation. They may become confused, disorganized, dependent, needy, regressed, or childlike behaviors. They may also be depressed or unmotivated or uncooperative. Therefore, we need to make sure that we are looking out for those and be able to recognize the behaviors as they start changing in a patient. Psychiatric symptoms, conditions, and histories are common. Patients admitted to the inpatient unit may arrive sicker. 1 in 4 patients are not diagnosed with a psychiatric illness due to patients' fear, stigma, cultural, and among others. Often psychiatric diagnosis is not recognized, shared on medical units until patients show signs and symptoms. Some of those recognizing barriers produces poor outcomes and quality of life. The patient will be less healthy, feel less supported. They have increased morbidity rates, premature mortality, problems navigating the health system, have no regular health care, and do not have primary health care providers. This increases the risk of complicated symptoms due to substance use diagnosis and psychiatric illness. Plus, adding medical diagnosis provides the nurse a challenging case. Treatment is complicated and may cause overwhelming feelings to the nurse and the ability of caring for the patient. The discharge length of stay will cost more money. For follow-up care, the patient may not want to be seen due to complicated case. Also, increased symptoms and complications worsening the medical condition, decreasing the healing, treatment adherence, and communication from the patient. Patients stop taking their psychiatric medications, which worsen the underlying symptoms. Dual diagnosis is another increased symptoms with complication, and of course, with the aging population, we'll have more diagnoses. Discharge planning: if you have poor communication, it will be difficult with placements. Acute conditions will increase the longer length of stay of the patient, and for chronic conditions, the follow-up care will not be followed up by the patient. Impact of stigma: patients may feel shame, embarrassed, or feelings of being out of control or anger. They have mistrust of system, us against them, increasing resistance, which equals non-adherence. The use of restraint adds to crisis behaviors. Some of the signs and symptoms of depression, anxiety is due to lack of an ability, interest, willingness, motivation, memory, concentration, or decision-making problems. Reduced communication, increased patient avoidance, reduce adequate and appropriate care, patient's wellness, healing quality of care, patient satisfaction, and nurse satisfaction can increase complications and increase the length of stay. What are some of our own stigmas as nurses? Decrease in patient satisfaction causes longer length of stay. Some psychiatric medications causes withdrawal symptoms and underlying behavioral health symptoms. Manipulation, medication seeking, non-compliant, patient avoidance, safety risk, and mistreatment are some of our own stigmas that we create against our patients. Fears, feelings, and attitudes create poor care and fear of the unknown. Labeling our patients such as crazy, medication seeking, or violent is often used and is not an appropriate diagnosis towards our patient. Thus, we're misunderstanding the symptoms, and it creates a barrier to patient's treatment. Stigma. Nurses must establish rapport, build trust, promote safety by observing patients and/or own barriers, using simple words for signs and symptoms. Communication with patients, family, providers, and colleagues will increase into disciplinary treatment, thus improving the treatment of the patient. Patients with psychiatric and/or behavioral signs and symptoms can be difficult and draining. Nurses' barriers from the evidence shows increased workload, fatigue, and burnout, tight management, organizational budgetary restraints, lack of support, resources, knowledge, and skill training. There is a communication problem, not adherence to treatment, resulting in complications. Then it is added to stress and challenges of providing care for the patient. Our own fears and feelings are common, but they can be contagious. They can worsen the behavior of the patient, and many complex reasons exist to why nurses feel inadequate or challenged when caring for patients with psychiatric symptoms and difficult behaviors. Nurses need to know they play an important part in promoting better patient outcomes. Recognizing you are important. Fundamental nursing skills offered for symptoms in the management of behavioral health. The assessment is very important. Therapeutic communication, patience, open mind, confidence, flexibility, because not everything is black and white, respect, dignity, and understanding. Understanding in the aspect of where is the patient coming from. What is the reason that they're demonstrating such behavior? Then we may offer medication, comfort care, and risk prevention. Recognizing psychiatric conditions. Chronic. It is a lifelong pattern of behavior. Usually will be in a crisis situation. You always have to remember that our goal is to manage, minimize, and stabilize. Always remember that we as the staff members do not use aggressive approach towards the patient, try to fix the problem of the patient, or engage in a power struggle. This is the end of part 1. Thank you.
Thank you and welcome to part 2 of Medical Patients with Psychiatric Symptoms and Illnesses. I am Leticia Flores Conchola and I'm a PhD candidate for North Central University. Thank you for participating in this research study. Part 2 objectives is to understand the factors that contribute to your patient's aggressive, explosive behaviors, intervening proactively by anticipating the situations in which your patient is most likely to explode, assess the 5 major pathways affecting the executive skills, and reduce aggression violence by replacing incentive punishments with collaborative decision making. This will help the patient develop the skill to be more flexible, solve problems, and handle frustrations more adaptively, and reduce hostility and antagonisms between the staff and the patient. Collaborative Decision-Making Program. This program is a model of understanding and helping patients with social, emotional, and behavioral challenges. The approach is based on the understanding that each patient have their own unique strengths and vulnerabilities. It is an approach that can assist nursing staff in gaining an understanding to reasons patient is struggling and how to help them. What is the reason the patient is exhibiting challenging behavior? In some patients, there's skill deficits will exhibit in challenging behaviors. There's a developmental delay or learning disability in some key cognitive skills areas, including the executive functioning, which means the planning, organization, impulse control, emotional regulation, which is the frustration tolerance, flexibility thinking, social skills, and language processing. Patients who have difficulties and easy to become upset is due to the inability to be flexible, adapt, and/or have low frustration tolerance. As the nurse, explaining what is going on is the best thing to do. Sometimes, as a nurse, you have to repeat yourself over and over and over again until the patient understands what you are trying to tell him or her. When does a patient exhibit challenging behaviors? The demands being placed upon the patient exceeds the skills. Patient must respond adaptively, which means a skill deficit and the environmental demand. It is an unsolved problem. So what happens here is when a patient has the demands of the environment or the skill deficit, they will have unresolved issues and they will not be able to dissolve what is going on in their lives at this time. Due to a variety of factors, most of these patients lack the crucial cognitive skill essential to handling frustration and demands for flexibility and adaptability, have significant difficulty in applying themselves when they are most needed. These patients are not choosing to be aggressive, violent, or non-compliant any more than a patient who chooses to have a reading disability. Behind every challenging episode is a skill deficit and a demand for that skill. The difficult behaviors. The difficult behavior is the byproduct of a learning disability in the domains of flexibility, adaptability, frustration tolerance, and it's about delayed development, not poor motivation. The treatment goal is to educate patients lacking cognitive and emotional skills. How are we going to do the teaching? Well, we have treatment tools. Patients and staff work towards mutual satisfaction solutions to problems that are underlying difficult behaviors. The staff also emphasizes and focuses on being proactive in solving and preventing the problem before it occurs. The 5 major pathways. The 5 major pathways are the executive functioning skill, the language skill, emotional regulation skill, social skill, and cognitive flexibility. Now we'll present each one, executive skill, then I will also show you examples of the deficit. The executive skill, we should be able to have thinking skills associated with the frontal lobe of the brain, enabling one to do the clear, organized, reflective thinking among the frustration that is crucial for solving problems in an adaptive, non-impulsive manner. Shifting cognitive set, the ability to shift gears to make transitions in activities and thinking smoothly. Organization, planning, and working memory, thus allowing the patient to use hindsight and forethought to solve problems in a systematical fashion. The deficits, they have difficulty in shifting from one activity to another, have difficulty anticipating problems, have difficulty in sorting through different solutions to organize a coherent plan of action, and they're reflexing negatively. They will answer with everything as no, because they have a difficulty in how to solve or find a solution to a problem. Think about patients that you have taken care of in the past, and think about what are those difficult times when shifting from one activity to another has been difficult for you. Now, this is the reason why the patient behaved the way that they did. They have an executive function skill deficit. Now we'll speak of language skills. This sets the stage for labeling, categorizing, communication, management of emotions. So the deficit's going to be the patient may not be able to identify or articulate their concerns, be able to label their emotions, have a problem-solving vocabulary, such as, I need help, can you please help me? Can you come over and explain to me what is going on? Those are little things that the patient may not be able to communicate to you. When trying to process situations, patients can often be heard saying such as things as, shut up, get away, I don't know, I don't care, you can do whatever you want, it really doesn't matter. And that is because they are not able to communicate what they're really feeling or what they really want to let you know that they need. Emotional regulation skills. This is cognitive skills one uses to control, decrease, and regulate emotions outside of the content of frustration. So this one has a separation of effect. So it's the ability to separate one's emotional response to a problem from the thinking one must perform to resolve the problem. Here you'll find goal number 2 and goal number 1. We're going to start with goal number 2. You want to think clearly during frustration times. And number 1 is stay calm enough to do goal number 2. So goal number 1 should be your number 1. Though goal number 2 is you really have to start thinking clearly before you really act upon something. So that's the ability to separate one's emotion response to the problem and start thinking clearly in order to perform or resolve the issue that is going on. And sometimes even ourselves may have some disconnection in that, but patients that are in a crisis situation or have a disability will not be able to do emotional regulation as appropriate as what we would want them to do. Emotional regulation deficit skills. The patients have difficulty with chronic grouchiness, irritability, fatigue, high anxiety, and agitation. These chronic states make dealing the frustration difficult. Patients will find the energy to look good in certain situations only to fall apart later. So this is sometimes when you find the honeymoon phase of a patient. They're behaving, they're acting nice, but then they're not able to emotionally regulate their feelings. Therefore, they become grouchy, irritable, they're fatigue, anxiety, and agitation, so they start yelling and screaming at you. Cognitive flexibility skill. The patient have difficulties in functioning in rigid black and white ways. They have difficulty handling the grays of the world, literally and concrete in their thinking. Often adhere to predictability, routines, rigid, flexible rules. They have difficulty focusing on the big picture. The distortion is I'm stupid because they are not able to focus on the big picture. Things will never work out for me. That is usually because they're thinking literally and concrete and they're not able to solve or find a solution to a problem. It's not fair. Nobody likes me. You always blame me for everything. People are out to get me. The only way to maintain one's self-respect is through fighting. Social skills. Patient has poor perspective taking and appreciation of how one's behavior is affecting other people. Poor appreciation of how one is coming across, poor appreciation of social nuisance, poor social repertoire in starting conversations or enter into a group situation. This is an example of the 8 executive functions. The executive functions are skills used by individuals to organize and act on information. An individual may struggle with one or more of the functions, causing an interruption of functioning of the individual. You will find the skill, what does it mean, and how it looks like. The Collaborative Decision-Making Model, CDM pathways. The goal is to allow the adult to pursue expectations, teach the deficit thinking such as a cognitive skill, reduce aggressive behaviors or breakdowns. A patient becomes aggressive or has a breakdown, the patient is not able to think clearly. Learning or processing does not occur. Aggressiveness and breakdowns do not indicate deficit skills. Patient's motivation is not the key. An ability to remember the consequences of a prior event during frustration is unlikely to be of help in the future. Factors. Understanding the pathway skill deficit, be aware of the option for responding to problems, unmet expectations, and of what each option accomplishes. Recognizing deficit skills reduces frustration, aggression, and/or violent behavior. So this is one that we need to, as nurses, we need to have the patient become aware of other options and how to meet expectations. So if they are able to recognize the deficit skill, they're able to reduce the frustration, aggression, and violent behaviors. The plans is controlling, which refers to the staff handling a problem and or unmet expectation by commanding the patient to follow the staff's expectation, threatening or imposition of consequence towards the patient. This creating a potential aggressive environment. So the staff is trying to control the patient and what the patient needs to do, how to act, and also solving their problems. Eliminating refers to nursing staff reducing or eliminating the problem and or unmet expectations by removing unnecessary demands or expectations of the patient, thus creating a no limit setting environment. So basically what this means is that the nursing staff will allow the patient to do whatever they want, become aggressive, break everything on the unit without having any type of limit setting. This is more of what happens when a patient becomes aggressive and we're not able to meet the demand of the aggression at that point. The positive one is a decision making, and this is the one that we want to follow. It refers to where nursing staff and patient are engaging in a process which will produce mutual satisfaction solutions to problems. Nursing staff and patients will discuss the problem, unmet expectations, and or concerns, and they will come up with a solution together, but allow the patient to come up with a solution and not you as the nurse. Thus promoting communication, allowing patient to improve a decision-making skill and flexibility. So this is the one that we want to follow. We want to follow the decision-making, and this is the positive one. We're going to work together and meet halfway. And again, we need to make sure that we are able to distinguish and see the signs and symptoms when a patient is having an issue with any of the 5 pathways. Timing is everything, so there's a challenging episode and are highly predictable. So we really need to pay attention in what do a 2-minute assessment of the environment, which that means is we go into the room, the patient is laying down on the bed, we can see their nonverbal skills and how they're acting or how their voice, maybe they're starting to get louder and louder. So we become proactive, which is the plan that we want to use, the PDM, which is crisis prevention. We want to do interventions and plan and be proactive. Well before highly predictable challenging episodes occur again. We don't want to be an emergency plan or a crisis management. We want to be able, when that happens, the interventions is reactive and occurs emergently, and it's in the heat of the moment. So we want to be proactive. So we always want to be proactive. So dealing with the decision making and proactive plan, we are able to handle situations before they escalate to aggression or violence. We want to build rapport with the patient, understand the patient. We need to know what are the triggers that are causing the patient to become aggressive. We need to think before and not in the moment. We need to ask ourselves, what should I do before? Do not ask yourself, what should I do when this happens? Always before, never in the moment, always before. I can't emphasize that. So we always want to think before it happens. So be proactive and not reactive. We need to solve problems proactively, figure out with the patient what is happening, what are some of those triggers, and maybe change. Maybe there's the patient is cold and they need a blanket. Maybe the light that is coming through, or the sun that's coming through the window, is overstimulating for the patient and it's hurting their eyes. Little things like that we need to kind of think before we start acting or trying to find a solution for the patient. We want to ask them, so what can I do to help you? So reminder, aggressive behaviors are highly predictable, so we're able to notice beforehand. So a 2-minute assessment of your environment is really, really important when you're going into a patient's room. Steps for Plant D, which is understanding, empathetic, problem solving, and invitation. Plan D is understanding. We want to be aware of the patient's feelings. We want to know reasons for their behaviors. What are those triggers that the patient has that potentially can cause aggression? Adjustment of differences. Willing to show kindness. We need to show kindness to our patients and be careful with the tone of voice that we use in our own body language. Have positive feelings towards the others. Always remember that sometimes we are thinking about the patient and that they're drug seeking, so they're constantly asking for medication, and as a nurse you get tired of that. But always think about, what if that was your loved one? So positive feelings towards others is really important. Understanding the patient may be challenging to some, so trying to understand the patient is very, very important, and trying to see where they're coming from. A lot of times it could be the patient has had trauma in the past, such as being in a different hospital, and now currently the hospitalization is bringing bouts of memories of what happened in the past. Maybe a nurse mistreated the patient, so we really have to try to understand where they're coming from. A lot of times we have to understand, because some patients come over and over and be hospitalized, and we see them and we get to know them, and sometimes it could, because the patient is challenging, we try to understand the reasons that the patient is coming back. Maybe they don't have money to buy the medication. Maybe we can help them in a way that asking the doctor to give them a cheaper medication, or try and see if we can find any kind of solution to helping them. Understanding others is all about observing and listening. We need to listen to the patient. This is one of the most difficult things to do as nurses and nursing staff, that we tend to think that we're listening to the patient, but there's so many things behind in our thoughts and in our subconscious that we're thinking about, versus really listening to what the patient is saying to us. And a lot of times when we don't listen, we end up failing the patient ourselves. Reading the signals that the patient sends and taking them into account. Always look at the big picture and see, what is the patient really telling me and what is really going on. A lot of times they may be telling you things that are going wrong in the home, and that's the reason why they keep coming back. So reading the signals of the patient that they're sending, and taking them into account. Understanding is reading the body language. Sometimes the nursing staff may receive more information about situations from what persons are not saying to you, but what the body is telling you. Let's say the patient is grimacing. Well, and culturally, the patient may not want to ask for medication because it's not something that we need to be asking for. We need to be tough, and maybe it's yin and yang, or with prayer I'll be able to get rid of this pain, or I just need to be tough because that's what it's always been. So reading the body language of the patient is really important. Making sense of the reactions. So the skill of understanding others helps predict what people might feel in a certain situation. Maybe you start talking about the new diagnosis the patient just received. We need to try and see and predict how is that patient going to react to the situation, and again try to understand where they're coming from. It also allows the nursing staff to make sense of how the patient reacts. So how the patient is reacting to a new diagnosis is going to be up to us to look at and see and try to understand where they're coming from. And building the skill, it's not always easy to predict or understand how someone else is feeling. But in some nursing staff are better at it than others, but just about everyone can improve with this practice. We can, again, understanding is really, it's more than just being empathetic. It's a one step higher than that. So we need to kind of see where the patient is coming from. If that was you, how would you react? If that was your mom, how would you react to situations? Improve with listening. People who are good at understanding others are usually good listeners. Research shows the better the staff listens, the easier to develop a therapeutic nursing staff-patient relationship. Again, listening is important and trying to understand where the patient is coming from. Again, listening is important, but really listen to what the patient is telling you and not say, oh, yes. And maybe every now and then repeat what the patient is saying and trying to make sense of what they're saying, or if you really understand what they're trying to communicate to you. Plan D, being empathetic. The goal is to gather information to achieve understanding of the patient's concern or perspective on a given unsolved problem. Start by explaining the observation. I've noticed that. Then proceed to ask, what's going on or what's up? Depending on how the relationship that you have with the patient, you want to be empathetic with them, and you want to let them know that you have noticed in the changes. And then, can you tell me what's going on? If you have a relationship such as maybe you build a good relationship with the patient and you're able to say what's up, then that's a good thing too. You can use those words. Be specific and ensure concerns are defined by the patient. Allow the patient to tell you how they're feeling and what is going on. Ask the who, what, where, and when of the concern. Use clarifying statements such as, can you be specific on what happened? Let me see if I understand correctly. So you're clarifying what the patient is telling you. And this is important because this means that you are listening to the patient. Remember, listen, stay neutral, non-defensive stand. Do not let your emotions play a part. Do not rush through the conversation between you and the patient, and remember to listen again. You must clearly understand the patient's concern to move forward. If not, the patient's not going to move forward and potentially can interfere with the treatment plan. Plan D, defining the problem. The goal is to ensure the staff's concern or perspective is entered and given consideration. My concern is, or I see the thing is, the definition to the problem still needs to be resolved. This is a solution-free zone, so as nursing staff, we need to not find the solution for the patient. The patient has to come up with their own solution. There should not be two solutions. There should be two concerns. If not, the nursing staff and the patient are engaged in a power struggle. So again, there's always two concerns. It could be the patient's concern and the nursing staff concern, but it's never two solutions to a problem. So it's always going to be two concerns, but not two solutions. Again, listening to the patient is really, really important. Plan D, which is the invitation. The goal to brainstorm a solution is addressing the concern of both patient and the nursing staff. Let the patient know that you're doing it for he or she rather than to him or her. Let the patient know that you're doing it for them rather than to them. Demonstrate that you're vested on the patient. So show that you are willing to help the patient, that you are interested in what they're saying to you, or interested in what is going on in their situation at this time. Allow patients to discuss solutions to the concerns. The solutions need to be is a team effort, so it needs to be coming from both and meet each other in the middle. So that is what Plan D and the invitation is. So we need to find a solution to the concern and meet in the middle. Solutions may include being realistic, mutual satisfaction, and team effort. It can be all three or at least two of them. What to do while waiting for Plan D to work? We want to understand the patient's deficit skill. We want to decrease using the Plan D to decrease aggression and or violent behaviors. We want to increase the use of Plan D to solve problems. The development of solutions will increase by using Plan D. Decrease of challenging behaviors will reduce and or be eliminated. So this is a nutshell for the Collaborative Decision-Making Model, or CDM. You want to gather the information to achieve the understanding of the patient's concern or perspective of a given unsolved problem. Number 2, you want to consider the nursing staff members concerned of the unsolved problem, leaving the situation open until the nursing staff and the patient can reach a middle ground. So again, it has to come in the middle. And number 3 is have the patient and the nursing staff brainstorm a solution to form a realistic and mutual satisfaction action plan. And this is when the patient agrees to work with the treatment team and work with you as a staff member and not become aggressive or violent towards you. Hello, my name is Leticia Flores Conchola, and I am a Nurse Central University PhD student. And you find me now, I'm going to speak to you on the medical patients with psychiatric symptoms and illnesses, part 3. Again, University Health is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credential Center Commission of Accreditation. In order to receive your contact hours for this continuing education activity, the participant must attend the entire program, complete the evaluation tools in EDS, and also complete the post evaluation that you will find also in the EDS program. Once you're successful, the completion has been verified. A certification of successful completion will be awarded for 1 hour for part 3 only. There will be a 4-hour accreditation for you. Credit hours for you. The planning committee members and presenters, authors, content reviewers of this nursing professional development activity have disclosed any conflict of interest and have been resolved by the planning committee. Again, you will be receiving your certificate of continuing education electronically. The objectives is to integrate interventions to promote positive interactions between patients and nurses to increase the treatment and better patient outcomes by using the following: empathy, positive framing, self-check, self-awareness, confidence, limit setting, distraction, refocus or redirection, identifying, prevent and minimize, and interventions for personality disorder. Tools to use as interventions. Again, we will be speaking on the empathy, positive framing, self-check, self-awareness, confidence, limit setting, distraction, refocus, redirection, identify, prevent and minimize, interventions for personality disorder, and also interventions for aggressive and violent behaviors. Empathy. It is to understand the patient. Do not attempt to fix it. Listen to the patient and listen to what they're saying to you. You will pick up a lot of little tidbits of information when the patient is letting you know what's really going on. So please listen to the patient. Understand the big picture, the meaning of what is being communicated. Listen to what the patient's perspective of what is happening. Connect to underlying emotions such as sadness, fear, anger, and frustration. So a lot of times the patient will have some issues on the unit or become aggressive or angry due to the fact that they are feeling fear or anger or frustration. So listen to the patient and what they're letting you know. Offer genuine empathetic responses, not questions. This is really frustrating for you, and always make it about the patient and not about you. I can see how hard this is for you. I can hear that you are really struggling with this. I can understand. I get how painful this is. You feel, and this is kind of clarifying of what the patient is telling you. Decrease resistance, reduce problematic behaviors, diffuse risky situations, and improve feelings, symptoms, and situations. Again, empathy is trying to understand the patient and where they're coming from. So listen to what the patient is telling you. Positive framing. Motivation influences behaviors and change. Everyone has basic needs, drives, and desires. We can all relate to the needs for comfort, safety, to feel in control, be free of pain, thirst, hunger, fatigue, nausea. These are only some of the examples that we can relate to the needs of the patient. What is it that you're feeling? In case if you were the patient, what would you be feeling? Always put yourself in trying to understand where the patient is coming from. What is that you need? What is bothering you? Always make it about the patient. Communication. Recognizing and offer empathy. Connect to the motivations of the patient. Partner with patients reduces us and them mentality and the resistance. Use words that tap into patients' needs, motivations to improve symptoms and options and adhere to the treatment that you're offering to the patient. This medication will help you to feel more comfortable, calm your mind, help you think, memory, maybe to sleep, to feel more relaxed, more like your old self. So communication is really important. Again, positive framing is one of the most important things that you can do for your patient. Again, positive framing, it improves hope, willingness from the patient, responsibility is given back to the patient, promote healthier minds, believe in themselves, the adherence is increased, it provides empowerment to the patient and the ability to be able to make decisions a little bit clearer. It motivates the patient to get better, builds self-advocacy. Positive framing plus communication improves the care of your patient, because if you are doing positive framing towards the patient, then the patient will be willing to follow the treatment and take medications and also be able to deal with the treatment and what is going on with them right now. And even the trusting relationship between you two will be even more. Self-check. You really need to do a self-check when you are working with patients in the medical unit, especially if they're having some psychiatric symptoms or they have a psychiatric illness. Nurses describe psychiatry as being scary. It makes them uncomfortable. It's too touchy and feely. Nurses don't do the real nursing there. You lose your skills. You really don't do anything. They're walkie-talkies. I didn't go into psych for a reason. I don't know what to say to psych patients. When working with patients with psychiatric symptoms and or difficult behaviors, nurses often describe feeling ineffective, scared, anxious, unsafe, overwhelmed, manipulated, fatigued, disrespected, anger, stressed, frustrated, irritated, and unappreciated. How many times have you as a nurse felt this way? Or how many times have you thought about nursing as a descriptor for psychiatry as the ones that I've given? There are many examples of how nurses in psychiatry are being treated and how nurses feel about patients with a psychiatric illness. Self-awareness is really, really important. Again, self-awareness. How do you feel about taking care of a patient with psychiatric symptoms or a psychiatric disorder? You must take a moment, take a deep breath, really think about it and put yourself in the frame of mind that you are really going to do well and be confident about taking care of this patient. Try to let go of any stress, frenetic energy before even addressing the patient. Let it go. Ongoing care is the key. Seek support, outside interest, and vent. If you have to speak to someone, seek your PCC or any of your other colleagues or charge nurse. Learn to recognize personal feelings when working with patients. Again, it's really, really important that we recognize how we feel about patients that have a psychiatric illness or having symptoms. Also, identify barriers such as stigma, a crisis, communication, labels, fears, and feelings, which may be worsening patient signs and symptoms such as their behaviors. When we show that we're afraid, when we show that we are not willing to work with the patient or not even speak to the patient, or that we are having, we feel uncomfortable and not confident, the patient will pick up on that and they will manipulate a little bit more. They will, the relationship between you two will not be as a good relationship as to when you are feeling more confident. Sometimes it's the small, simple things that make the biggest difference. A lot of times, ask the patient, are you hungry? Or can I bring you a snack? Do you want some water? Maybe they are cold or something. So kind of offer the small things. Maybe just listen to them. Even if you're a little scared and afraid, just standing there and listening to the patient and what they're telling you makes a big difference in their lives. And it also shows that you care about your patient. Redirection. What is redirection? So we want to refocus their attention and energy or impulses into something similar, but safer and more appropriate. We want to channel patients' current actions and behaviors into alternative, more appropriate actions, and offer opportunities for patients to learn better ways to manage feelings, urges, and impulses, such as if the patient is throwing things around the room, maybe you want to give them a pillow and say, if you really want to you feel that you want to throw things around, maybe use your pillow instead of your telephone, or use your pillow instead of trying to throw yourself on the floor. So who does it work best with? Who does it work best with when you're redirecting? When the patient is angry and frustrated, they're anxious, they have needy dependent behaviors, they're manic, and those with inappropriate or childlike behaviors, and they're hallucinating. The best thing to do is to redirect them. If a patient is hallucinating, do not give in to their hallucinations. You just let them know that you don't see what they're seeing or you don't hear what they're hearing, but that they're safe and you're there to keep them safe. Limit setting is really important, especially for those with personality disorders. So we really want to make sure that we do limit setting, not only with the personality disorders, but with every patient. Assertive communication, respectful for the self and the patient. The I statements, make sure that you use the I statements. Describe and explain in simple, clear, and direct manner what the behavior is expected. So if the patient is throwing themselves on the floor, you need to let them know that we really don't feel that it's the right thing for you to do, to be throwing yourself on the floor. So why don't you just sit on the bed, and it's a lot safer for you. So make sure that this is what you're doing instead of throwing yourself on the floor. Consistently hold patient to expectations for appropriate behavior. So redirect and limit setting is always going to go hand in hand. Who does it work best with? Patients with personality disorder, those with manipulative, needy, or dependent, or have difficulties with inappropriate behaviors. Substance users, potentially violent and aggressive patients. Again, what limit setting works best with patients with personality disorder or patients with substance use or potentially violent and aggressive patients. Distractions. What is a distraction? The tool to divert or focus one's attention to something completely different and or new to stop a problematic behavior. So who does it work for? Distraction. Who does it work best for? For a delirious patient? For a demented? Even the middle or later stages for the demented patient? Anxious, disorganized thinking, delusional, developmentally disabled, depressed patients, manic, and pain. So distraction, what is it that you can do for distraction? Maybe use music, use a card game, maybe talk about old times with the patient and how maybe San Antonio about 20 years ago and what it looked like. Maybe an old movie on the television. If we're able to get old movies on the television, that could be a really good distraction for some of the patients with dementia. We want to identify aggressive behaviors and violent or assaultive behaviors way before it happens. Typically, this doesn't occur out of the blue, suddenly, or without warning. There's always warning signs about when a patient is starting to become aggressive or violent or assaultive. So we want to make sure that we're pay attention to the warning signs that can present, causing the patient to escalate. The goal is to keep everybody safe, not only ourselves as nurses and the team, but others, maybe family members and other patients. Identify, recognize, and pay attention to the hairs on your neck, the red flags, that gut feeling in your stomach. Trust your intuition. Usually, do not avoid or ignore these instinct feelings. You really want to be able to identify the fact that the patient is becoming more aggressive. The louder they get, the more upset they become. So we want to see what are those identifiers, and also know what are the triggers that the patient may be having. Prevent and minimize. We want to de-escalate the situation. Maybe we can use the SAPNA management of aggressive behaviors and try to speak to the patient to de-escalate the situation before it explodes. We want to prioritize safety. Nurses who were assaulted reported afterwards having known that something was off or wrong, but they ignored their instincts. Again, pay attention to your gut feeling, your intuition. Do not avoid or ignore the instincts or the feelings that you're having. Again, wringing of their hands or grimacing of their face. They're starting to punch their fist. They become louder and louder. So we really want to be able to identify and minimize their aggressive behaviors. And again, our goal is to be safe. How to prevent and minimize, we want to use the least restrictive measures to the most restrictive measures. So you want to model that what you want the patient to do. So respect the patient, keep yourself calm, set clear and firm expectations for the patient, which requires team communication. Everybody has to be on the same page, so everybody's telling and communicating the same thing to the patient. Approach with calm, confidence, firm. Self-check and awareness again comes with this. So if you're afraid, make sure that you do self-check and self-awareness if that's what's going on with you. But then take slow deep breaths and build your confidence, and you be calm and a firm voice. The more they see you that you're not confident to come into the room, or that you're afraid, they will act out a little bit more. So modulate your voice to patients. If the patient gets loud, your voice gets quieter. So we want to make sure that if they get louder, we get quieter when we speak. Ask the patient, what is it that you need? Again, place it back to the patient. Demonstrate respect for patient and patient's personal space. So we want to respect the patient. If they are cussing at us, we're not going to cuss back at them. We're not going to tell them, you're a loser because this is not going the right way. You need to stop talking to me this way. You really want to make sure that you maintain a personal space between you and the patient. Never give your back to the patient. Always make sure that you are able to leave the room if need to. So don't ever give your back to the wall. Demonstrate respect to the patient. Again, if they're cussing at you, you're not going to cuss at them back. But you will let them know, look, it's really disrespectful. I'm really trying to help you, so please don't speak to me in that manner. Maintain safe personal space and exit strategies for self. So maintain safe personal space for yourself and exit strategy for self. So you need to make sure that you don't give your back to the wall. Stress verbalization and praise positive behaviors. Always stress verbalization and praise positive behaviors. You really want to let them know that, hey, I really thank you for not cussing at me anymore. That was really helpful in our communication. Offer symptom management options like for sleep, nausea, or pain. If they're having pain, they're going to get upset. You don't want to give them the medication because, of course, they're drug seekers, or they're here just to take medication. The doctor gives them whatever they want. But pain is subjective, so we really want to control it the best that we can. Even though we may have some biases against it, we really want to put those aside because it's really not about us, it's about the patient. Place yourself near exits, have exit plan before you enter the room, and know the protocols. What are your protocols in case that you stay or you are in a room where the patient becomes aggressive and then you are in the room where you can't get out? What is it that you can do? Allow client opportunities to vent, discuss feelings and anger. Always offer options. Use the last resort. Then you can use the most restrictive measures, which comes down to having the patient be placed in restraints. So we really want to make sure that we use everything else before we go into restraints. Interventions for personality disorder. We have discussed this before in part 1, but we're going over it again. It's never enough to discuss, especially with personality disorders, because we tend to forget, because it's something that we really don't see as often, but sometimes when we have the patient in our unit, it's going to be more difficult to deal with. So set and maintain limits with consequences. Explain the expectation and keep them. Don't ever go away from what you've set expectations for your patient. Require the patient to take responsibility for their own behavior. You want to identify inappropriate behaviors and discuss alternatives. Assess for suicidal thoughts and gestures and actions. Demonstrate a matter-of-fact attitude when a patient acts out or exerts the events. Exaggerate events, Discuss with patients how their behavior affects others and explore alternative actions. You want to provide a safe environment and be aware of manipulative behaviors. Show acceptance of the patient, and you want to separate the person from their behaviors. Again, a lot of times we have that stigma against personality disorder patients because of their behavior. It's really a disorder that they have, and we really need to work with them by setting the limits. We want to set expectations and keep them. We want to require the patient to take responsibility for their own actions. You want to discuss alternatives when there's inappropriate behaviors. Demonstrate as a matter of fact attitude when the patient is acting out or exaggerate events. Discuss the patient how their behaviors are affecting others. Provide a safe environment and be aware of the manipulative behaviors. Interventions for aggressive violent behaviors does not typically occur out of the blue, as we've spoken before, suddenly or without warning. We don't want to miss warning signs because they can escalate patients' behavior quickly. The goal again is to maintain safety. Assess for current escalating behaviors and threats and risk factors. You also want to assess for history of harm to others and assaultive behaviors, and that you will find it in your navigator in the admission process. So there is a part there where you can assess for history of violence. Document and communicate violent triggers with the team. Also communicate it with the team. You want them to know that there's violent triggers. What is it that makes a patient act out, or what has the patient done before to calm themselves down? Sometimes they just want to be left alone. And you want to identify the aggressive behaviors before. Recognize and pay attention. Trust your intuition again, your gut feeling. If it's there, something's going to happen. We want to prevent and minimize. We want to de-escalate before it actually becomes explosive. We want to prioritize the safety component of the unit and also the nursing team and others. Nurses who were assaulted reported afterwards having known that something was off or wrong but ignored their instincts. The reason I'm repeating this is because, again, we need to make sure that we pay attention to the patient before they become explosive or something happens on the unit. So trust your instincts. Again, assess for history. Document and communicating violence triggers. So you really want to make sure that all those things are being done beforehand. At university hospitals, safety is a priority, and we do have 2 programs that are recommended And again, one is satori, alternatives to management of aggression. Safety is their number one. So all have the right to physical and interpersonal safety. The values all have value to exist and not due to the behavior. Cooperation is mutual benefit in times of crisis. Respect, reserved to be treated with respect. Teamwork, most beneficial for a sage or a supportive environment. Acceptance, no one should be judged. Again, satori, alternative to management to aggression, which is SAMA. So if you are not SAMA certified, make sure that you go and let your PCC know so you can set up for a class for the SAMA, and you'll be able to do part 1, and which is the talking to the patient, and then the other parts is how to handle an aggressive patient in times where they become aggressive and want to hurt themselves or others. The other program is a diversional activities. It provides meaningful patient-centered activities to patients with degrees of dementia, but not only dementia, also trauma, injury to, which is a T. We want to offer it to a traumatic event, to a traumatic brain injury patient, but also to patients that are hallucinating. Maybe patients that are having anxiety or depression. We want them to be in an activity. So we want to reduce behaviors such as restlessness, anxiety, agitation, and help prevent complications associated with hospitalization. So giving them some distraction or diversion of the behavior, it really works best if we are able to provide them with some type of activity. Nurses may place an order on the diversional activity assessment order, and it's not an order, it's more of a standard order that we are able to do as nurses, so it's a delegated order from the physicians. Rehabilitation therapy team evaluates within 48 hours to determine the patient's current dementia stage or whatever it is that we're doing for the diagnosis of the patient that we're recommending for the diversional activities. And then appropriate diversional activities are based on the patient's physical and cognitive abilities. So each stage is a color. So they're color coded. So green is early stage, yellow is moderate stage, orange is late stage, and red is the end stage. What that means is, depending on where this goes with the demented person, but basically we can go with how well can a person cognitively participate in the activity. So they will do the assessment and then we go from there. And this is the end of part 3. I will soon provide you with part 4, which is our last one, and then I will give you your references so you can go ahead and do the EATS, which is our program to receive your continuing educational hours for your participation in my program. Thank you so much. Welcome to Medical Patients with Psychiatric Symptoms and or Illness, Part 4. This is Leticia Flores Canchola, and I'm a nursing student for North Central University, and thank you for your participation in this research. Identifying the goals. We have 3 goals for the summary toolkit of interventions. Integrate 7 of the symptoms and management tools. We want to be able to implement interventions for better patient outcomes and promote teamwork. The patient tools, we want to symptom management. So we really want to manage the symptoms of the patient. So we need to get in contact with palliative care or comfort care. Because the patient is at the end of their life, we need to make sure that we do contact them and advocate for them to have that consult. Educate on responsibility and empowerment of your patient, making sure that they're able to participate in their treatment. You want to practice alternatives. So such with pain, we want to make sure that we practice alternatives. For example, we want to do massage therapy, music therapy, aromatherapy, and give them coping skills to deal with the pain instead of giving them medication all the time, and finding something that really works for that patient. We want to understand their needs of the patient. So it's always asking them, what is it that is needed by the patient? You want to enhance self-esteem and believe in themselves so the patient feels more able and capable and in control of their treatment. Flexibility, especially with those patients that have some manipulative or aggressive behaviors. You want to be able to be flexible with them. You want to offer 2 to 3 options, pros and cons. So you want to give them and set limitations on them and give them 2 pros and 2 cons. And if you follow this is what will happen. But if you don't follow this is what can happen. So you're giving them the options to do well, or they want to do the part where you remove things from them. Educate symptoms and ways to control the symptoms also. So you want to educate them on the symptoms that are occurring or what can occur with the medication, or what is if they're freshly diagnosed with a new diagnosis, we want to educate them on the symptoms. We want to promote healthy ways to cope with the situation, calm and reduce a disturbing and uncomfortable experience. A lot of times, so a lot of the things that we don't know is what the patient has experienced in the past, such a trauma. Maybe they have been traumatized before, so they really don't like men coming into their room because maybe they have been raped before, but we're constantly putting a male inside their room. And a lot of times we have no option but other than having a male staff member. But what can we do to prevent the patient from being re-traumatized? We as nurses can go into the room and also assist on whatever it is that the patient is needing in order to provide the comfort and a good experience to your patient. What are the patient needs? If we meet the patient needs, they'll be motivated to participate in their treatment. You want to ask about the symptoms. What happens when you're telling me that when it's really loud outside, your pain increases? So you want to assess, identify, and clarify about the symptoms that are occurring on the patient. So you also want to assess possible causes. Maybe medication is causing side effects and they really don't like the way it feels, but they really don't know how to tell you. So we need to assess for that and ask and identify. Maybe it's possible pain or maybe anxiety that it's causing. So what's usually works for the patients, such as what has been their coping skills in the past and how they've dealt with situations. If this does occur with the medication or with any of the other traumatization or re-traumatization, or what is happening with their disease process currently. What is currently working for you? So you want to build on these answers that the patient provides for you. So in order for you to be able to have better outcomes of the patient, you also want to know what doesn't work. We also want to know what doesn't work for the patient, because if we know what doesn't work, then we're going to try the things that do work in order to prevent the patient from not being motivated to participate in their treatment. So we want to know what works and promote those. Our goals again is management, minimizing, and stabilizing. We want to manage and reduce the frequency and severity of the problematic symptoms and behaviors. We want to improve nurses' ability to provide the most optimal care that is possible. We also want to enhance the patient's roles and efficacy in their own care. So we really want to make sure that we are managing and minimizing and stabilizing the patient in order for them to be able to participate in their treatment. So we want to make sure that we know what are some of those signs and symptoms that the patient is having that may be related to psychiatric disease process. So psychiatric symptoms, there is no permanent or quick cure. So we can't place a Band-Aid over the brain because that's not a way that we care for patients with psychiatric symptoms when they have a psychiatric disease or illness. Sometimes what happens is we just have to be patient, very patient with the patient that is having psychiatric symptoms. The reason for that is because medications need to be stabilized in their blood system. So a lot of times you may not see the difference until 4 weeks later. So again, coping skills, patience from you, confidence, and also limit setting and making sure that we do not traumatize or re-traumatize the patient while they're under our care. We want to maintain and motivate the patient to be part of their treatment. Pursue education. So as nurses, we need to make sure that we maintain ourselves educated on understanding mental health and also mental illness or diseases process. So we want to be able to continue our education on that. We want to be able to identify barriers. What are those barriers that possibly can prevent us from providing the best care for our patients for better outcomes? What are some of those common behaviors that can impact nursing care, such as aggression and manipulation? You want to document patients' report of psychiatric symptoms and conditions. The reason that we want to document that is because we want for the other nurses that are oncoming or nurses that are going to be working with this patient to know what is going on with the patient. So a lot of times what happens during reports in a medical setting, we do not provide information as a patient as a whole. We provide only of its parts. So we do not provide the component of the psychiatric part or the psychosocial behaviors or psychosocial needs of the patient. So we only do the medical component. So we need to be broader and be more holistic in caring for our patients, and also providing report. When we're providing report to others, we need to make sure that we provide them a complete report of the patient. Reconcile medications and substance taken. What is the patient taking? What is it? Are they toxic? Are they withdrawing? Have they recently stopped a medication? For example, if the patient is on a depression SSRI, antidepressant medication, SSRI, if the patient abruptly stops that medication, what can happen with the patient is that they were going to have a withdrawal symptoms, and we need to be able to see what are those adverse effects. Awareness improves identification and care, and it reduces problems and keeps the patient safer. So we want to be aware in the improvement identification and also the care, so we can reduce the problems and keep the patient safer. Self-awareness approach is really important. So we want to face our own fears. We need to be confident. We want to assess ourselves and what is going on. Do we have a stigma, and do we have some negative connotations towards this patient because they're drug seekers, they're manipulative, they're aggressive? So we need to be honest and identify personal beliefs, thoughts, and attitudes towards the patient. So once we do that as nurses, we also need to make sure that we project calm, confident approach, and we want to model the behavior that we are seeking. We want to establish rapport, promote safety, and establish trust. So we really want to listen to the patient. We don't want to fix them, or we don't want to fix the situation. We want to listen to our patient. We also want to do and promote positive reinforcements of the desired behavior. So we want to praise the patient. Align yourself with the patient and the patient needs. So we need to make sure that we're aligning with them and meeting the needs of the patient in order to improve. Interventions for a toolkit. Again, you want to use a team approach. Communication is really important between the team, especially if you're having manipulative patients or aggressive patients, or any of the patients that are having some issues. We always want to make sure that we're using the team approach and consistency. We want to reassure our patients. Motivating the patient also provides a more, the patient to be able to be motivated to attend to their treatment. We want to consult. If we need to consult with the psychiatric team, we need to make sure that we do that. Case management. If case management needs to be involved usually be involved in the part of where the patient will be able to discharge. Where is the patient discharging? Or maybe the case manager already has had the patient before. So how can we improve care to reduce symptoms from that patient? Partner with the patient for symptoms management and common symptoms. You want to listen to your patient. The patient is always the expert of their own experiences. We can't take it for granted and assume that we know the patient. We really need to know what the patient is going on with them in order for them to share their experiences, and they're experts of their own symptoms and their own health. Partner with them to understand their needs, motivations, and manage symptoms. Ask the patient about how they cope when experiencing anger, voices, stress, and feeling out of control. What are some of those coping mechanisms that they use to prevent from getting angrier or feeling out of control? Maybe there's a panic attack or they have anxiety disorder. So we want to know what are those coping skills that they use, and do they work? Do they really work? So we want to keep using them. If not, we want to give them different tools. Enhance their sense of control and responsibility. We want to make sure that we enhance their sense of control and responsibility. Also, we want to reduce problematic behaviors, signs, and symptoms. So in order for them to reduce the problematic behavior or signs and symptoms, we really need to listen to our patients. Again, it takes 2 minutes to get to know your patient. Apply current symptom management tools. Ask what makes it better. What makes it better? A lot of times we just go with whatever it is and we keep doing the same thing over and over, but maybe they want to have a cool compress or a hot compress other than just having their medication. Offer and practice new choices for managing symptoms. You want to share information with your patient and support the therapeutic decisions. You want to set limits for expected appropriate behaviors. You want to identify high-risk patients and their behaviors, and you need to remain calm if the patient is in control. Safety starts with you. Safety starts with you. Violence typically does not just occur. There's always warning signs beforehand, so we need to be looking out for them and always maintain a safe environment, not only for the patient and for you, but also for the rest of the team and also the rest of the patients. Again, so safety starts with you. Be able to identify risk and early signs to prevent and minimize the problem. We want to identify and manage high-risk patients and behaviors, so assessing their history is important. We want to prevent, minimize, and stabilize. We want to ask, what is the need of the patient in order to assess for motivations and needs. We want to apply the least restrictive behavioral method first. So you want to use self, environment, distraction, de-escalation, redirection, symptom management. So we always want to use ourselves by listening to the patient or talking with the patient. What is in the environment? What are some of the distractions that we can provide for the patient? What are de-escalating ways of de-escalating the patient? Maybe you are escalating the patient more, so maybe you want to get another person from your team to come and try to de-escalate the situation. Always use a safety stance. So prevention, remove hazards to self and the patient. So you want to remove anything that can potentially harm the patient, yourself, or others. Use the least restrictive to most restrictive. So you want to do a one-to-one first, then provide a PRN, and then the last resort would be the physical restraint. The one-to-one, you can provide medication first before you decide to do a one-to-one for safety or for suicide. Well, for suicide is different, but for the one-to-one for safety, you want to see if maybe medication, maybe advocate for your patient and have the doctor come and see them. The team approach, you want to document all the signs and symptoms of the patient and making sure that others know during huddle, provide them with information, not only provide them with the parts of the body that are broken, but you also want to do a holistic approach on that. So you want to communicate everything that is going on with the patient, to include the psychosocial, the psychiatric issues or illness that the patient have, and then provide them with with the parts of the body. Communicate regularly with the team. A team that communicates will work better together. So assess for information and support, including outside resources and providers and family. Limit setting, again, is really important. Describe what you do and what the patient would need. Use simple and clear ways. Also do the expected behaviors, give them 1 or 2 options. Model assertive, so communication again is really important. So when you model assertiveness, I can see that you are upset. I want to help you, but first I need to know what's giving you the trigger, what is it that's making you upset. Assess for support, intervene with all appropriate resources as a team. advocate for psychiatric consult, provide appropriate follow-ups as needed, seek for collateral data such as confirmation from families or even looking at the patient's chart for history. We also want to have some healthcare providers give us some information, and then review history to determine if the symptoms are possibly related to a psychiatric condition. So again, we want to not only ask the patient, ask the family, ask the provider, ask the health team, but also determine what are some of those symptoms that are possibly related to your psychiatric condition, so the patient is able to tell you. But also in the chart, you can find out a lot from the chart in itself. Some of those common psychiatric symptoms in medical surgical patients, you'll find anxiety disorder related to PTSD, mood disorder related to depression, bipolar, suicidal ideations and behavior, psychosis or psychosis for schizophrenia or psychosis for the patient. And personality disorder may manifest as a lack of cooperation or aggressive behavior or violent behavior. Common psychiatric symptoms in the medical surgical patient, you also will find that delirium is part of the common symptoms. You find it delirious will occur due to infection, fever, post-op, polypharmacy, stroke, intracranial tumor, heart failure, substance toxicity, sedatives, and also excessive or deficit of stimuli. So we really need to make sure that we're looking for possibilities or looking and assessing for delirium. And then again, what are some of those causing factors of the delirium? Substance use disorder. We want to know for intoxication, what are some of the complications that the patient may have, the withdrawal alcohol syndrome. So we need to make sure that we're following the protocols, pain management in the opioid-dependent patient. Another one is dementia. Dementia also has sundowning syndrome, and it usually is exhibited during the time that after 4 o'clock has usually been my experience, that patients start acting agitated, acting out, or become confused. And those behaviors, those three, the confusion or the acting out or agitation, will be demonstrated due to restlessness. You'll have an increase of falls during that time. The patient may be calling out more or yelling. They may be crying and you really don't know the reason why. They may be wanting, if they were able to walk, pacing or wandering. They're more fearful. They have mood swings. They're happy, sad, and then they become really aggressive towards you. Paranoia, hallucinations, and shadowing. We'll talk a little bit more about shadowing in a little bit. Interventions, you want to reduce the noise distraction by providing snack activities. You want to have quiet time on the unit. You may want to play soothing music or music of the genre of the patient. Maybe the patient was a teenager during the 1950s, so maybe play 50s music at that time. Maybe an older television show, such as maybe a black and white. You may want to read to the patient. Maybe that's soothing to the patient and will be able to be calm at that time. Close the curtains or blinds when it starts getting a little bit darker to minimize the shadows, and turn on the lights for the patient so you can minimize the shadows that are being portrayed on the walls and things like that. And also it could also stop the confusion of the patient. The other thing that you want to do is, for the example that I want to give, is your CMT. When the patient is on a video monitor, the patient may think that is an alien, or it may be a robot that is trying to eat them. So you really need to be creative in some of these things, and the reason the patient may be feeling paranoid, or they're crying and pacing, or they're fearful, because we really need to assess the environment in order for us to know what is happening. With the shadowing, is the patient wants to shadow the nurse usually, and that's what happens, is the patient wants to be shadowing the nurse and doing everything that the nurse is doing. So sometimes it could be very kind of interruptions for the caring of the other patients. So again, providing that distraction can really, really help. Other psychiatric consults in the medical surgical setting you may want to refer is with acute stress reaction, aggression or impulsive behaviors, agitation, alcohol and drug abuse, including the withdrawal states. You want with anxiety or panic attacks and changing in mental status, child abuse and even elder abuse, coping with the illness, death, dying and bereavement, delirium, dementia, depression, and then determination of capacity and other forensic issues. Other disorders could be eating disorder, factitious disorder, geriatric abuse, pain, personality disorders, PTSD, psychopharmacological due to the medical illness, restraint, sexual abuse, and even suicide. The key factors in promoting a safe environment: you want to establish rapport, build a trust, and promote safety. You want to assess the patient. You want to use a team approach. You want to manage the common signs and symptoms of the patient. You want to know what are those warning signs of violence. You want to access support. You want to be able to identify early signs, and it's a key to be able to identify also the barriers. Prevent, minimize, and stabilize by applying the least restrictive. You want to assess and support the patient. You want to promote safety on the unit, not only for the patient, but for yourself and also the rest of the team and the patient. Other patients, you want to do your self-assessment. You want to stay calm, and you want to praise your patients. You want to enhance motivation in order to provide them empowerment to provide and continue with the treatment. And that is the end of part 4. Thank you so much for participating in this research project.
Please follow the instructions below to receive credit to each section of the program. Print your CNE certificate. This ends our first SAPNA Annual Educational Conference Series. For more information, please contact Gerard Santo Domingo, on the given information provided below.